Okay, I'm Devinder. Prof Tan have already introduced me to you. I am a physiotherapist by background. I actually worked in Ministry of Health for 16 years. I am actually in Ministry of Health groomed before I came to academic. Working with Prof Tan, I think you will know that my passion is working with older people. But I do some work about musculoskeletal as well, but I try to do more related to older people. So today's talk is about exercise interventions for falls, a Malaysian update. I think 2 sessions before this, in our falls meeting or seminars, we've talked about assessments. And we've got quite a lot of work done in assessing older people for falls, and we have actually identified a few assessment tools, and TUG or Time Up and Go is a really good assessment tool for older people in Malaysia. But when we pooled our data from Malo and LRGS tour, we realized that TUG didn't appear to come up as a correlated tool. So looking back at the data, we have younger, older people compared to many studies overseas. So this population is community dwelling older people. So we really think that it is like, you know, the older people are still very active. They are still contributing in the community. So probably it's not just balance. What appeared to be stronger is the strength. So we think that we not just need to look at balance when we look at community older people, we also need to look at strength as well. So I'm very lucky because I have a few students working in this area now in Falls, and one of them is Janet Wong from Sarawak. So she's done a little bit of work for me and done a little bit of literature review to share with us. So thinking that Asmida will come aboard, so we only actually did a very small review and left the rest to her, but never mind, we will be able to discuss. So in Malaysia, we have very little evidence on exercise for prevention of falls. The 3 studies that so far we've got is all done in Selangor, and the latest was the modified Otago. This is from Prof Tan's team herself. Individually prescribed exercise by trained physiotherapists, 30 minutes per session, 3 times a week for 3 months among community dwelling older adults with history of 2 or more falls, and the outcome was significant improvements in mobility and balance in the group that had the Otago, modified Otago intervention. And then we have Motalbi et al. This one is a progressive resistance training. It's a pilot study, and it's also group-based exercise. Sorry, it's also group-based exercise supervised by qualified exercise trainer. It's about 60 minutes, 3 sessions for 12 weeks. This was done in resident homes, and the outcome again was improved balance, functional mobility, strength. And this was 2015 by one of the physiotherapists, my colleague as well, Maria Justin, and this is UPM, I think, Azizan. Combined behavioral and exercise interventions. Again, this intervention is about 6 weeks combined with behavioral therapy, brought about significant improvement for, I think, those. So we actually have not looked at if intervention can decrease number of falls, but generally if you look globally, most exercises, exercise interventions, or even combined interdisciplinary care have not proved very much about decrease in falls. mainly because falls is multifactorial, so I think it's really difficult to prove or show that there's a decreased number of falls. But there are 1 or 2 studies that have shown that there is a decreased number of falls as well. So Janet have helped me to look at Southeast Asia. So in Singapore, why we were looking at Southeast Asia before we talk about intervention is because like what Muhammad presented from one of his the systematic review, it showed that we really need to tailor our exercises based on cultural or countries, because it may not the exercises done overseas may not fit us very well. So we are looking into this as well. So in Singapore, we found 2 studies. Both studies, this is by Prof. In their study, they also actually targeted for frail older people, but they did show some improvement in mobility and TAP. And we have another one also showing some improvement in TAP with exercises. Next is Thailand. So if you look at Thailand, we have more studies, and they use a lot of traditional interventions. For example, Tai Chi in 2 studies, and 2 traditional dance, Thai dance exercises, and all 4 showed improvement in falls risk, time up and go, fear of falls, and also mobility. But again, no significant change in falls. But there's one, this Thai dance study, they did follow up prospectively after 6 months, and it showed decreased number of falls. So very much looking at something that is done in the community, and Thai dance is maybe very acceptable in India. So any exercises that can be adapted to the community may help. So looking at Vietnam, we only have 1 study, and it looked at Tai Chi. Again, there is significant improvement in cognitive impairment and cognitive status and falls efficacy. Fear of falls. So in Indonesia, only 1 study. This is La Fisca. It's some physical exercises in Indonesian language, and just range of motion, balance, muscle strength, games, and deep breathing exercises, led by facilitators. Not sure who the facilitators were. Must be those who train in exercise, and done in institutional older adults setting. We have significant lower risk of falls, improved balance status, and also health status. So we are looking at Southeast Asia. The general idea is to see what kind of exercises is available for evidence to develop our own exercises, because although we have 3 studies, we really don't know what is the best. So we thought of coming up with another protocol of exercises for community. And to look at that, we need to look at evidence first, and out of the 11 studies, we analyze to see what type of exercise is best. So mostly, if you look, it is group-based exercises that has been adapted in Southeast Asia. Although there is home-based exercises, but very small number. But with the COVID-19 situation, I really think that we should also work on home-based exercises so that people can also do exercises on their own as well. Group-based exercise so far has been shown to be good because you have peer support, and I think really the environment is a little bit different, where you have, like, friends to communicate and compliance is better because you go there because of friends, you want to, you want to socialize. So maybe group-based exercise should be the way to go for Malaysia as well. We don't know. We are contemplating on the exercises and designing what would be best. Now, what about frequency of exercises? Although we know the more the better, but how many times can these older people come for the exercise sessions? It's good if we can tell them to incorporate physical activity or balance exercises in their daily routine, but it really does not happen in many people. Not just older people, I think even younger people. Adherence or compliance to exercise is not the favorite pastime for people. What we saw in Southeast Asia mostly were 3 times a week, which is about 55%. Twice was about like 27%, and more than 3 times was only 18%. So number of studies with different timing, how long was the intervention? So if you look at number 4, it's about 60 minutes was what was adapted in most studies. About an hour, that means. And the number of studies with duration of exercises, how long did they conduct the exercises over the period of time during the intervention of the study? Mostly were for 3 months. We have very little for 6 months, and we have one for 6 weeks and one for 8 weeks. Reason for how many weeks we are not sure. Mostly people will try to look at evidence how many weeks would be effective enough to show some difference. Now, based on whatever information we got from Southeast Asia, we are trying to come up with a 6-month supervised group community-based exercise program in Malaysia. So what we really want to do is an exercise program that is actually conducted for falls prevention and done in the community. So we are very hopeful that we'll be able to work with Pusat Aktiviti Warga Emas, which we call PAWE, because they have the facility and older people there. It's near to the older people's homes, and they can actually go and participate in the activities conducted in PAWE. So we are going to develop these exercises to provide some care in the community, initially supervised by physiotherapists, and the hope is in the future to train older people themselves or volunteers, or if the government can pay a little bit of money to trainers who can actually then run these exercises routinely in the community, it will be really good. So this will be done in Sarawak for the first time. We will be having 4 Pusat Aktiviti Warga Emas: Kuching, Lundu, Miri, and Lawas. So we hope to have the experimental group over here, and then the control group over here. There are some issues environmentally. I think they may not be similar, but we'll try to match these older people as much as possible, so that we don't get this question, environmentally they're not the same. How can you compare these 2 groups? Now, this is the inclusion exclusion criteria that we are going to use. We're going to get older people who are at a falls risk with a time up and go test more or about 11.2 seconds. This is taken from LRGS to our cutoff point for community dwelling older people. Now, what will be included in the intervention protocol? This is our early discussion. From the early discussions, we've come up with a protocol that will include warm-up and cool-down exercises. We would love to include strengthening exercises because this is where our community dwelling older people need to have strength training as well, and of course balance training for falls prevention and improving balance, and probably balance training will be adapted from Otago, and we will have some aerobic exercises. We are going to include step training because there is sufficient, well, there is sufficient evidence to show. There's sufficient evidence to show that stepping training is um, step training is beneficial for improving balance and decreasing falls. And finally, we would like to include a little bit of mat exercises because many of the older people, this is from very much the clinician perspective, where a lot of older people want to be on the floor. So, you know, they want to do their prayer, they want to be having activities where they need to sit on the floor and come up. So we'll include a little bit of mat exercises as well in this protocol of exercises. So this is the description that we have come up with so far. We want to base it on progressive three levels. So we need to be progressive and to have a certain level of exercises, we need to base it on something, and it will be easiest if we base it on box scale because it's very subjective. To see if they are feeling it hard, and then we will, get them to the lower level exercises. For alternatively, we are also thinking of using loads from 60 to 100% load with 1 RM repetition maximum. This the therapist will know, or the exercise therapist will know how to measure this. And the total time for the exercises, it will be about 1 hour 15 minutes with all the exercises we discussed earlier. And of course, in between, we would provide rest in between if anyone requires it. Finally, we want to encourage people to continue at least 150 minutes activities in a week. So even if they are not active and not doing anything else, they would be still having this 150 minutes of activity in a week. And those who are continuing we would advise people to continue functional activities, physical activities, to keep fit and to have enough physical activity. So this is what we have planned so far. So we hope that these exercises can first be tested in the community to see if it works. And if it works, we would love to then look at prospectively, maybe 6 months, 1 year, if we have people with falls and the falls number have decreased. It will be good in a way because a lot of older people who have history of falls can then be discharged to the community to join this program at the community level. Of course, it will not just be exercises, it will be combined with education. So we want to educate people about falls as well. It will also include how to come up from stand up, or come out of a fall. Once you've had a fall, how to get up of the floor and what to do next. I think for the start, we just would like to include this, and in the future, maybe we would really like to have a platform where people can access falls exercises easily. We expect volunteers to be able to do as well. So I don't know, this is sounds ambitious. So we actually worked Prof Tan with Prof Tan's team and another student, Chia Ping. she has looked at what older people would like to have on a web page if we want to do falls education, and what do they know actually about falls education. So the results really came out that because we did mostly in the urban area in PJ, most of them are older people who have been to the geriatric clinics, I think. So they know what is falls, they know what to do. They talked about a lot about modifying the environment to prevent falls. They also talked about how they modify certain things for their mother and not themselves for preventing falls. And finally, we've come up with the results of what they would like to have in a web page. If we can come up with a web page for them to do some self-management and self-education of falls. So that's all from me actually. Regarding assessment, we are also in the process of automating a falls assessment, which can be administered by older people or caregivers or even people in the community to be able to see if you have a high risk of falls, and also just to provide awareness to older people and the community about falls and routine assessment. So at least if you have something automated, simple, you can just do it on your own and see if you have a falls risk. You may want to enroll in falls prevention exercises in the community itself.
Thanks,
So
thanks
that's all.
very much.
Prof. If there's any questions or any discussions, we can have it now.
Yeah, that's really good, because we always keep saying exercise, exercise. It's not about just flinging your arms around, and that's just such a lovely exposition of what it actually takes when you actually develop exercise programs for older adults. You know, what points to consider and things like that. That's so beautifully done. So a lot of times our older patients are willing to pay for a doctor consultation, but they're not so willing to pay for a physiotherapy because they think they can just do it themselves. And you've just shown us that, you know, really there's so much to think about. Yeah. So we would really welcome questions. If you've got any questions, please type it on the chat. And you know, there's also, we have got 15 minutes for you to kind of fire away if you like. So do type it in, and you know, if you are willing, we can actually let you unmute yourself and, you know, actually speak out your questions. Any questions now?
Maybe while people are typing, I would like to highlight that, you know, falls prevention can be done by tele-rehab. And yes. Because of COVID-19, I think this is one area that we should really look into. Hopefully there are people who want to join us, you know, to join hands to do, because we don't have enough hands to do it.
Yeah, there's a question from Awamia. Do you want to unmute yourself and actually ask your question? Yeah, because I'm not sure I can understand your question.
Thanks. Can you hear me?
Yes, we can.
Yes, sure.
Thank you for the nice presentation. Actually, my question is, we know that especially in older people, more concerned about their physical health, and some older people are not motivated to do exercise. So my question is, all participant of experimental group has accepted the this intervention, because they are demotivated. How can I address this problem? Can you get my point?
Yes. Thank you, Mr. Awal. Started the exercises. We will be doing a pilot first, but we have run other activities or exercise-based programs in the Pusat Activity Warga Emas, which was in Selangor and Kuala Lumpur. so far the older people were very happy to do the exercises.
Yeah.
It's just that they want therapists to be there. They want somebody to be there to supervise them. We just thought we might start with supervised exercises. Again, we need to keep the group a little bit small when we're doing group, because we don't want to see anyone falling while doing exercises. And in group, if you have only one therapist to keep an eye on, we could manage, I think, about 8 to 10 people. And these were cognitively frail older people. Of course, cognitively frail, they have high risk of falls also, but so far, so good. They are very motivated. There are few things that influence their adherence and their compliance. It's about the supervision as well. So we had this therapist who is actually very good with older people. She allowed the older people to give her a hug and a kiss, and spend some time talking to them as well. So they are, they do not want to miss the exercise session. They do come for the exercise session. So we are hoping the same would be for the other centers as well. But I think that is the one thing that we learned, that to keep them motivated, it's best to have a group activity, and also to have a very good person who has very good PRO, older people, to keep them together and keep them coming. So we've done 3 months of supervised exercises. We've got the pilot results showing that there is improved both cognitive and physical performance. But we had, and then we did 3 months of home exercises, and coincidentally, the home exercises in the PKP, we are now waiting to go back assess them to see if with the home exercises was there any improvement. So fingers crossed, I think we can keep them motivated. And once we get them addicted to exercises, just like, if you get up every morning, you need to brush your teeth. So we want them to be like, if they don't go for the exercises, they will be restless. They need to go for it.
Okay.
Yeah, exercise is an addiction, isn't it? Yeah, because it's about. Thanks very much, Dr. Awal. It's a very useful question. Yeah, maybe because a lot of times we think that, oh, COVID-19 actually the older people are stuck at home, they can't do their regular exercises, but actually there's actually some sort of increased health awareness during this period as well. Apparently the exercise machine warehouses are actually sold out, because people actually are very bored at home, so they're actually buying exercise machines, and everybody's like following YouTube videos of how to do Zumba and things like that to try and improve their physical health, because they cannot do anything else anyway. So it'd be really interesting to see whether this phenomenon is also happening to our older adults, whether there's actually an increased health consciousness rather than everybody, letting themselves going all flabby kind of thing. Yeah, what do you think, Devinder? I think we always assume the worst, but sometimes we'll be pleasantly surprised, right?
Yes, we always assume they can't use technology, but they are managing very well actually. And during this COVID situation, we actually did a small survey just recently to see how they were doing physically and cognitively and psychologically. We haven't got the full results, but what we've got presently is they were actually very happy at home. So we are shocked, because psychologically they are not lonely, they are happy. So we asked them what were the reasons for this, and they said they were very happy because a lot of family members were at home working from home, so they had company. So we were just chatting, maybe we need to think about telling the government, let us work from home some days to accompany the older people so that they are happy as well.
Yeah.
For physical activity, we haven't done results. We hope to see the results very soon. And we also actually compared the cognitively frail and the non-cognitively frail to the control group. So the group that had intervention, when we analyzed the data, those groups who had intervention, they were had better performance cognitively and also physically compared to the control group. So we are now thinking if we can have these community-based exercises or programs, even if we have situations where they can't go to the community activity, they will still be able to carry out whatever they have learned at home, and we believe that they will be performing better, or they will be more resilient
Okay.
group
So,
compared to those.
yeah. Prof. Maria Justin says, I always tell my older patients exercise has been part of a lifestyle. Would you like to just share with us what your experience is with communicating with older people about exercises? Maria? Maria Justin, are you here?
Hi, Dr. Maria. Where are you?
I think I've lost her. I don't know where she's gone. Yeah. Okay. And then ADFM. Who from ADFM is this? Yeah, just to share. Yeah, our elderly clients love chicken dance. I don't know. How do you find chicken dance, Devinder? Do you like chicken dance?
I think it's about fun.
Really? Okay.
The older people also like to have fun. So, chicken dance is like, having fun. I think it's a good exercise because to keep people in the group, keep them exercising, it has to be fun. You cannot ask them to just do routine, mundane exercises, which is so boring. So dance activity, chicken dance, they really have a lot of fun doing it. They laugh, they enjoy. So I think that's why they love it. I think it's just like anyone else.
Yeah, Nora Shikin. Yeah, do you want to unmute yourself and ask the question? You around? Nora Shikin? She's a bit shy. Okay, are you coming? No? Okay, how about hospitals?
You want to unmute, you can't find the unmute button.
How about, she's saying, hi, Dr. Devinder, how about for hospital setting?
Well, we haven't thought about hospital settings because we think there is not enough hands for people to be doing falls prevention in hospitals. We rather the physiotherapists in hospitals treat cases that are requiring acute care, need urgent care, and let the other older people who are actually, community dwelling, who are, able to, independent, to actually then take self-charge of their management. But a little bit of guidance and supervision at the community, I think, will be really helpful. You can start exercises in the wards if you have history of falls, like fractured neck or femurs and all. And I think after that it should be really discharged to community, so that we get more people to be in exercising, rather than having a lots of work in the hospitals, and getting less care for those patients who really need the care actually.
Yeah, totally. Yeah, quite agree. Yeah. So I've never believed that fall prevention can actually happen in hospital when it comes to secondary fall prevention in the community, isn't it? Because the longer you keep someone in hospital, the more likely they're going to fall when they go back out. So best to get them out and sort them out outside. Yeah, because they decondition in hospital and everything, isn't it? Yeah. So okay, we've got another couple more minutes before we have our kind of break and also divide people into groups again. I'm sure people have questions. Maybe not just to Devinder, because we didn't manage to ask Mohammed questions earlier also, and Elizabeth also didn't have too many questions. Maybe a little bit about virtual exercises. Yeah. So obviously I from a geriatrician point of view, I'm very protective of my older people, and now I want them to do everything 100% virtually because I really don't want them to go out and catch COVID-19. I want to put them in a bubble, and I want them to just do everything virtually, so they don't have they don't touch another human being. But exercises lend very well to virtual, isn't it? I mean, what's been your experience, Devinder?
So far, we haven't experienced any virtual exercises with older people, which we think now we have to do. We really need to see whether they will comply.
Yes.
But looking at globally, there was this program where they just did movement snack three times a day online via Facebook. There were so many older people coming online on Facebook to do the live exercises, which was really nice. And no fancy full equipment or guidelines. There was only an instructor who was conducting the exercises, and it was like in small snacks in a day, and people enjoyed it. People joined it. I think we are going to have a future population that is going to be very IT savvy, including older people. So we should not underestimate that they cannot come online to exercise.
Yeah. So just to share with you, Amira is actually one of our nursing students who's actually looking at social participation, and she initially started doing it with the semi-rural community in Negeri Sembilan, and then of course this COVID-19 just basically, because she was the intervention she was doing was based in a mosque, so we went, okay, you're not going back there ever for the rest of the pandemic. So then we decided to go back to our original PISA cohort and call them back, and then Amira's now doing some just exercising with them every morning to see whether they could actually comply with virtual group exercises, and then comparing those who chose to do exercise at home on their own versus the ones who actually joined the group sessions. So we didn't have to devise our own exercise because Selena Koo from sports science already devised the exercise ages ago. We just used the same one. So because there's no time. Yeah, but it was so interesting that they all complained 7:30 was too early in the morning. So I was like, oh, this is really interesting. And then we realized actually the advantage of doing virtual exercise is you don't have to wake up at 7:30. Because the reason to wake up at 7:30 is because to go out to the park, you have to go at 7:30 because 8:30 too hot already. But with the virtual exercise, you can do anytime. Morning, evening, nighttime also can. Yeah, so actually virtual exercises has its advantages. Yeah, and and then our older people always say cannot get to the park because traffic, nobody to take them, no buses, and buses are not safe for older people because they don't wait for older people to sit down, they already drive off. So all these things actually overcome with virtual exercises. Yeah. So I'm actually quite excited that the COVID-19 has given us new opportunities and forced our older people to explore new horizons. I'm sure you feel the same thing as well, right, Devinder? Because it's like Miri so far away. We have to wait until Janet come before Miri can get exercises. If they had actually embraced virtual in the beginning, then it wouldn't be so hard, right? Yeah.
To think about it, if you put it on TV, I'm sure there will be many people following it as well, because they watch TV as well, and if they are, they seem to like routine, right? We had this problem when we interviewed people during the COVID. Were they still going out? There were some people who were still going out. They just cannot break their routine to buy a newspaper or whatever. So the idea is to get them into a routine. So we can put it anywhere, Facebook, TV or wherever, and they need to follow at a certain time and they won't miss it. I think it will be good.
Yeah. Okay. Eng Kylie, do you want to unmute yourself? You get the last question. Okay, Kylie, are you going to unmute yourself, or do you want me to read out your question? Okay, I'll read out her question. Okay, hi doctor, how do we integrate exercises for older patients, perhaps in his or her lifestyle, who have fluctuating symptoms? For example, if the patient experiences dizziness for some of the days, while he does not experience it at some other days, while the vitals are normal. That sounds like a very complex question. Over to you, Devinder.
I think we really need to get them investigated first. Need to send them to Prof to see why are they having dizziness in certain days,
Talk about
whether it's
passing the buck.
or art or whatever. And and after that, maybe if it's safe, you know, I would not say no exercise at all. When they're doing their balance activities, they need to have someone beside them, or they need to be told that they need to be standing somewhere where they can hold on to something if they are doing the falls balance training. Ideally, it should be a solid kitchen desktop or a table rather than chair, because chair can topple over. So balance exercises are very, very safe. Even if you're feeling dizzy, you can always have a chair beside you and can sit down if you're feeling dizzy. So I think no excuse for not exercising. But with extra precautions, you need to inform the patient or the older person on what can they do if they're feeling dizzy, or they stop exercising for a while until they're feeling much better and then they continue again.